urge urinary incontinence is associated with urinary microbiome.
Mhm.
And those feelings of urgency, frequency, and having incontinence can be associated with UTI episodes.
Today, I'm speaking with Dr. Lindsey Burnett, a physician scientist in urogynecology whose research explores the pathophysiology of pelvic floor disorders. This includes urinary and fecal incontinence, pelvic organ prolapse, and recurrent urinary tract infection. I'm so glad we have this opportunity to chat. Thanks so much for joining me.
So excited to be here, Melissa. I really appreciate the opportunity to talk a little bit about clinical practice and research and how they intersect.
We have a lot of questions, so I suspect we will end up with 2 episodes for this podcast, but let's jump into some of the basics first.
I'm glad to see all the interest.
Yeah, there are a lot of questions from our community, so I'm really happy that we get a chance to answer some of them. And it would be awesome if you could share some information just about your background and your areas of specialty.
Yeah, absolutely. So I'm a urogynecologist in the United States. Usually to become a urogynecologist, you have to attend medical school and then residency either in OBGYN or urology. So you can come in from either specialty and then do a fellowship in urogynecology training. So from an OBGYN training perspective, which is my particular background, it's 4 years of OBGYN residency followed by 3 years of urogyn fellowship. There are urologists that are trained as urogyns too. And in general, they do 5 years of urology residency, followed by 2 years of urogyn fellowship. So overall, 7 years of training to get to where I'm at right now.
Yeah, it's a lot. A lot of people I don't think have even heard of urogynecology. Is it a new kind of area of the profession, or has it been around for a while?
Yeah, relatively new in terms of the subspecialties of OBGYN. I think it's been board certified or board identified for about 15 years, but in the grand scheme of things, compared to maternal fetal medicine or gyn-oncology, it's relatively new compared to those subspecialties. That and a lot of the clinical practice in terms of surgical practice and other things was previously performed by generalists, now is really deviated towards subspecialty training because we have more experience with those particular procedures.
Do you think a urogynecologist is a more appropriate clinician for someone with chronic UTI to see instead of a urologist?
I think so. In theory, our specialty encompasses a wide array of pelvic floor disorders, things like pelvic organ prolapse, urinary incontinence, fecal incontinence, but many of us also concurrently treat recurrent UTI or chronic UTI or frequent UTI. I think that there's reasons to see someone like us versus someone in urology. Some of those things are that pelvic floor disorders in general can predispose or interact with recurrent UTI in ways that might be meaningful or significant.
Yeah, that makes a lot of sense. I guess there's not the profession everywhere, so not everybody can access a urogynecologist, but it does seem to be becoming more common.
Yeah, definitely more common and becoming a little bit more accessible. I would say it's probably worth traveling to see someone if you can, but if not, making sure that you have good, strong communication between whoever your primary is, either urology or sometimes women have their recurrent urinary tract infections managed for their primary care provider, generally internal medicine, and then also your gynecologist, just because things like pelvic floor disorders, particularly pelvic organ prolapse, where the organs can rest a little bit lower in the pelvis, and sometimes women can have trouble emptying their bladder that can predispose them to urinary tract infections, can also be diagnosed. So if you don't have a urogynecologist that has both experience in urology and gynecology, having a combined care team that helps assess for both of those conditions can be really useful.
Yeah, it sounds like it would be very useful. And you're in a good position to answer this next question, which is, what do you think the difference is between acute, recurrent, and chronic UTI?
So I think this is really tricky. So clinically, we have sort of, I don't know how to say it, guidelines-based criteria. And the guidelines-based criteria are not really rooted in a true understanding of the pathophysiology of disease. So I'm going to tell you from a clinical perspective what we consider recurrent UTI, since we don't recognize chronic UTI as a different thing. And then I'll tell you as a clinician what I see in my patients and sort of how I differentially manage. And so from a clinical perspective, UTI is diagnosed based on a standard urine culture and patient symptoms, which we all recognize the limitations of that, or at least people that are in the UTI field and patients, I think that at UTI really recognize the limitations of these tests. But still based on guidelines, this is sort of standard care. And so if you have more than 3 of those episodes in a year or 2 in 6 months, we define that as recurrent UTI. We don't differentiate that from chronic UTI based on current practice guidelines. In real clinical practice, we see a variety of phenotypes of patients. So we see patients that have UTIs very infrequently, let's say maybe once every couple of years, and think of that as maybe a sporadic or less common UTI. We see patients that are having UTIs multiple times per year when we think of that as like recurrent and or chronic. And in my clinical practice, I kind of think of recurrence as being patients that have episodes of UTI symptoms and then fully resolve before then having another series of symptoms. But there are women that have symptoms persistently with flares, and I think of that as more of a chronic UTI picture. Now, from a pathophysiology standpoint, we don't know what differentiates this, like whether there are embedded bacteria in some women and not others. We don't have a specific test for embedded bacteria in the wall of the bladder, but we know that this likely occurs based on both clinical studies and preclinical studies suggesting that bacteria can be harbored intracellularly and then kind of reemerge to create UTI flares. Sometimes we can get a hint from what the culture results are, but again, within the limitations of our culture. So sometimes if I see women with the same urinary pathogen and the same antimicrobial resistance, but they're culture negative in between, and then it flares back up, it's a good indication that it's somehow living either in the walls of the bladder or somewhere in the body that's being harbored as like as a reservoir for that particular strain.
Right. And you mentioned the limitations of standard culture. Why is it that clinicians still rely so much on this test that's been shown to be inaccurate?
Because we don't have better options. So I have lots of patients come to me with next-gen sequence results and microgen sequence results, and it's basically all of the bacteria that are present in the bladder. And the problem with that is that we don't really know which ones to go after, and we don't know the best ways to necessarily target antibiotic treatment towards specific bacteria that are bad versus, other bacteria. So the problem with antibiotics is it's kind of like dropping an atomic bomb on a town and then hoping that the good people come back and the bad people stay away. It's not a very targeted approach to getting rid of the pathogens that are actually causing disease. It kind of is a more global picture that can wipe out good microbes as well as bad microbes.
Do you see that certain microbes are associated with recurrent UTI over others?
Yes, but again, within the limitations of how we can look at it. So based on standard urine culture results, we know that E. coli is predominantly related to recurrent UTI, as is Enterococcus faecalis. But there are now newer data, mostly from the Wolf lab, showing that there are other uropathogens that are not detected by a standard urine culture that are likely associated with recurrent UTI as well.
Okay. Do you think clinicians are in general getting a better understanding of recurrent and chronic UTI and therefore less likely to diagnose interstitial cystitis?
I don't know. So if you look at some of the current AUA guidelines, it's kind of up in the air. So there's definitely clinicians that still follow these sort of strict standard urine culture guidelines with symptoms as a way of diagnosing UTI, and therefore see anything that doesn't meet those criteria as being not a UTI, right?
Yeah.
And there are other clinicians that are starting to realize that there's kind of a spectrum of bladder health, right? And that the urinary microbiome probably plays a role in this spectrum of health, even if it doesn't meet, this extreme criteria of, X number of bacteria of a given type that's detectable by standard urine culture plus symptoms, that there might be things that are subclinical or currently subclinical that influence urinary physiology and influence urinary symptoms. For instance, we know that overactive bladder, which is thought to be, bladder urinary frequency and sometimes even incontinence, we know that it's supposed to be in the absence of an infection, but we know that urinary microbes now from research studies, urinary microbes influence lower urinary tract symptoms and seem to play a role in overactive bladder, and can also influence response to medical treatments and management for overactive bladder as well. So I think it's more of a continuum. And I think there are some clinicians that are a little bit more aware that it's becoming a continuum and we really have a lot to learn. And there are some clinicians that are very guideline based because we don't have a good handle on what that continuum is or how to manage based on that.
Yeah, I think that reflects the patient experience in this space. It's quite frustrating, but it is important to understand that there aren't any options for most clinicians to implement which makes it very difficult to help with patient
And most
outcomes.
clinicians have busy practices of other
Yeah.
things. They're not necessarily sitting around reading all the newest literature,
Yeah.
brainstorming how they can micromanage different things. They want to practice. They want it to be easy too, and they want it to be evidence-based, and they want to
Yeah.
provide practice that's standard, across the country or across the, through international documents, like what things should I be doing for my patients? I will do those things without necessarily having to think about all of the pathophysiology behind it until
Yeah.
we really understand and have definitive evidence to support other treatment modalities.
Yeah. Yeah. It really does need to be actionable for clinicians to be able to do something to help patients with this.
Well, because it's hard too, as a clinician, if you provide care that's outside of the scope of evidence-based practice and then something not great happens,
Yeah.
it's hard to rely on that too. So I think it's a balance as a clinician. So for me, in interacting with patients, I try to make sure that I've gone through, this is what the guidelines say, right? These are the things that are guideline based. These are the things that I'm supposed to do. And these are the things that we know in the literature. Let's discuss together what you've tried already, where you see things going, and what you're willing to try based on what we know right now. Anytime you're kind of developing something new in the field, it's always going to be a discussion between patients and clinicians about, hey, this is what we have evidence for. This is what we don't have evidence for. These are some things you could try. What do you have the bandwidth for? What works with your lifestyle? What makes sense to you?
Yeah, it's really important to have that kind of communication with patients, because I think patients do have quite a bit of knowledge about their own health and want to be involved in those decisions.
Yeah, I completely agree. And so I offer, let's say, standard care or guideline-based care. I explain why the guidelines exist, but then there's also circumstances in which there's clinical trials, things like urinary tract infection vaccines that are coming out, phage therapy that's coming out. So there's opportunities to sort of have treatments that are beyond the scope of guideline-based care, but with the knowledge that we don't really know the efficacy, safety, and other things for some of those treatments yet, or at least as fully as we might when they've been out for as long as some of these other things have,
Yeah, definitely.
So, I mean, vaginal estrogen's been along for a really long time. So, and I think one of the unfortunate things is, even though we have things that we know work, we don't necessarily know exactly how it works. So vaginal estrogen, we know, improves, vaginal microbiota in terms of lactobacillus populations, which is thought to make the urinary environment less hospitable to uropathogens. But the details of exactly how it acts, which molecules it acts on, either in the vagina, in the bladder, to allow lactobacillus to grow, is a little murky still.
Right.
So I think we could do a much better job too of understanding some of the treatments that we have that do seem to work. And then that way we can devise new treatments, based on those mechanisms to really enhance treatment of recurrent UTI.
Yeah, agreed. I want to jump back to the topic of prolapse, which you mentioned earlier.
Oh, yeah.
It'd be great if you can explain what urinary and fecal prolapse are and some of the causes.
So really we think of pelvic organ prolapse, and prolapse is predominantly through the vagina. So when we think about like cystocele and rectocele, or you hear about my bladder falling out or my rectum falling out, usually it's not the bladder or the rectum itself. It's the vaginal tissue that shares a wall with either the bladder or the rectum. So I wish I had a picture, but basically the vagina is in the middle, and the uterus is, if the uterus is still in place, the uterus and the cervix are on top of the vagina, like a superior in the pelvis, and then the bladder lies towards the front and the rectum lies towards the back. And so there's a front and a back wall of the vagina that are shared on the other side, with the bladder on one side and the rectum on the other. So when people hear the word cystocele or rectocele and they're told their bladder's falling out or their rectum's falling out, it's not the actual bladder per se or the actual rectum, it's the vaginal wall that you see prolapsing. So the vaginal wall can come out and it will look like a pink ball or pink tissue coming from the vagina. And so as the vagina has less support, those walls fall. And what can happen is it can impact urinary function and defecatory function, because now there's a distortion in the normal anatomy. And so what happens, or what can happen with women with pretty significant prolapse, is that the bladder can end up in a non-anatomic position and the urethra can get kinked. And sometimes women can have trouble emptying their bladder because of prolapse. And if you're unable to empty your bladder, that puts you at higher risk of urinary tract infection, just because the urine's sitting there for so long. Just like if you were to leave something in your fridge, even under conditions that are not meant for anything to grow in it, if you leave it in there long enough, it probably will grow something. And so sometimes being able to empty your bladder better can just help tremendously in the risk of urinary tract infection. And the treatment for pelvic organ prolapse, really, because this is tissue that's lax, that's lax predominantly after vaginal delivery and predominantly with aging. Those are the two major risk factors, but also can get worse with things like obesity and diabetes and anything that compromises tissue integrity. And the treatments are really to support the vagina in various ways. I'm going to back up 1 second. You don't have to do anything about it if you don't have any symptoms. So if you have no problems emptying your bladder and having a little bit of tissue lower in the vagina doesn't bother you, you don't have to do anything about it. But if you do want to do something about it, there are conservative treatment options, things like pessary devices, so a little ring or sometimes even a cube or a little like dish on a stick that go inside the vagina to help elevate and support the organs, akin to what a sports bra would be to help support breast tissue. Or there's surgical interventions for prolapse, most of which focus on sewing the top of the vagina or the cervix to strong ligaments in the pelvis to help support it. And by reestablishing normal vaginal anatomy, this can reposition the bladder into its normal position and improve bladder emptying. And then the same thing on the back wall of the vagina, when that's now straightened out, it can improve defecatory function as well.
Okay, and are there minor symptoms that people can look out for that could indicate a prolapse is present?
The number one symptom of prolapse is feeling bulging from your vagina. So in large trials where we've looked at screening questions, it's bulging from the vagina or feeling like there's bulging from the vagina. Women are really pretty good at knowing when their bladder's emptying and not emptying. So if you feel like your bladder's not emptying properly, you can ask your clinician to perform what's called a post-void residual volume. Usually you need to go to either a urologist or a urogynecologist for something like this, but you would empty your bladder and then they can do just even a little simple ultrasound on your lower abdomen to see how much urine is left in your bladder to check your bladder emptying. Sometimes you can feel like you're not emptying when you actually are. This can be caused by things like vaginal atrophy or tissue thinning. There's a variety of different symptoms that can occur with this, but really women are pretty good at knowing when they might be having trouble emptying. So it's rare for the opposite to occur where women are having trouble emptying and they don't know it. But if you're concerned about it, there's a very simple in-office test. The other way that they can check it is by having you urinate and then placing a small catheter through the urethra and seeing how much urine is left. It's normal to have small amounts of urine left, but if the number is greater than, 100 to 150 milliliters, you start to think about what might be going on that causes you to have incomplete bladder emptying.
Right, and that kind of brings up the topic of incontinence as well. People often ask if there's any connection between incontinence and UTI. Does incontinence cause UTI or does UTI cause incontinence?
That's a really good question. And there's really two sort of flavors of incontinence that we think about clinically. One is what we call stress incontinence, which is incontinence associated with coughing, laughing, sneezing movement, which is predominantly thought to be an issue with the suburethral support tissues, predominantly as a result of vaginal delivery and aging. So there's weakened support of the tissue underneath the urethra. And when you cough, laugh, sneeze, or move, just a little bit of urine comes out. The other type of incontinence that we think about is what's called urge urinary incontinence, which is that sort of you're feeling like you are trying to get to the bathroom and you can't quite make it in time because of this urgency and feeling like you need to go. So stress incontinence isn't strongly associated with recurrent UTI. Urge urinary incontinence is probably somewhere on a spectrum. So we know that urge urinary incontinence is associated with urinary microbiome, and those feelings of urgency, frequency, and having incontinence can be associated with UTI episodes, so that we know that some women only have incontinence when they have a UTI, and the rest of the time they're totally fine. And that's probably due to this irritation of the bladder, and probably urgency incontinence or some forms of urgency incontinence, I should say, are probably associated with urinary microbes and sort of subclinical urinary tract infection. So it can be, but it's very common to have incontinence only during UTI episodes as well.
Yeah, we do hear from a lot of people in the community that report that experience. Some people ask if there's a neurological basis for incontinence.
Yes, there can be. So there's a couple of things that can happen. So neuropathic conditions such as diabetes can increase overactivity in the bladder wall and cause incontinence. We also know that women can have trouble emptying their bladder as a result of neurologic conditions as well. So people that have had spinal cord injuries can oftentimes have problems with urinary retention and have what's called overflow incontinence. Like the bladder is so full that a little bit spills out
Right.
all the time. And so the treatment for that type of incontinence is basically emptying the bladder, usually by catheterization in those cases, since the muscle won't contract on its own. There's a special type of testing that we do to test for bladder wall activity and to look at pressures inside the bladder called urodynamics. And sometimes things like urodynamics can be really useful in helping determine what's going on in terms of bladder activity and whether the bladder wall has function or if it's overactive, like if it's squeezing inappropriately.
Okay. And is there an autoimmune element to incontinence?
I don't know. So I think we need a lot more research on it is basically the answer. There's some studies that suggest there might be, but I mean, there's autoimmune components to many, many, many clinical phenomena. And I don't think there's I don't think we have a clear origin or something that we can test for in the setting of incontinence.
Okay. One question that comes up a bit and we haven't been able to get a good answer for is, can gut bacteria cross from one organ to another or into the bladder rather than just ascending the urethra?
Okay, so Scott Hultgren's lab has some data on this showing that there's definitely a relationship between the gut microbiome and recurrence of UTI. But whether or not that's clearly a link that this is bacteria from the gut that somehow make it not transurethral over to a different ecologic niche versus things happening in the gut that release bile acids and metabolites into circulation that somehow influence either urinary microbes or urinary metabolites in a way that results in UTI, I think is yet to be really definitively answered. So he might be able to give you a little bit more detail on his work for some of that stuff. But I think the interplay for the gut bladder access is still a really ginormous subject of debate. Because there have been some studies showing food etiologies, particularly, consumption of chicken or handling of raw chicken, and some studies and dietary intake and influences for lower urinary tract symptoms. But I don't know that that's a direct thing, like that the diet somehow makes microbes move over, or diet influences microbes that already exist in the gut. And then those microbes release metabolites into the circulation, right? Because they're breaking down food products in the gut. Those breakdown products are taken up into circulation and serum, right? And then filtered through the kidney and into the urine, and that are somehow impacting the ecologic niche of the bladder, either creating a hospitable environment to certain urinary microbes or even directly acting on the bladder wall to have an influence in either immune response or susceptibility to UTI. Whether that's direct or indirect is really unknown, or at least in my mind is not conclusively known. And we have yet to sort of establish that in large clinical populations. So one of the things that we're looking at in my lab is starting to try to figure out the interplay between those things by looking at both gut microbiome and metabolome, urinary microbiome and metabolome, and seeing sort of which things come from where, and can we at least start to correlate what's going on in each niche.
Be great to go more
So,
into the science in episode 2. So hopefully we can
yeah,
record that in the
sorry.
near future. It was a really interesting area and we get a lot of questions about it, but it is something that we haven't found any good answers for yet, but it would
And I
be
don't know that
fascinating to know.
I don't know we have good answers, but
Yeah.
food is medicine. We know that diet affects longevity. We know diet affects lots of other aspects of health. So, what you eat is really, really, really important. So how specifically and what to do, I think is really open for debate, but food is just another form of medicine.
Yeah. Yeah, it's definitely an interesting area. And before we jump onto different conditions, it would be great to just circle back to treatment for prolapse. A lot of
Oh,
people
sure.
asked whether pelvic floor physical therapy can help with prolapse or other pelvic floor disorders.
Pelvic floor physical therapy absolutely can help with pelvic floor disorders. I think it's most useful in prolapse when the prolapse is relatively early.
Mm-hmm.
So let me back up and talk just briefly about pelvic floor
Okay.
musculature. So there's a sort of, how your abdominal wall sort of holds in your organs in your abdomen. There's a diaphragm of muscle in your pelvis too that helps support the organs of the pelvis. And so those muscles can weaken over time. They can get stretched over time, particularly with vaginal delivery, and weakening usually with loss of muscle mass with age. And so anything that can be done to sort of strengthen and help support those organs can help alleviate some of the symptoms of prolapse. These muscles, unlike your abdominal wall muscles, which you want your abdominal wall muscles to be high and tight all the time, right? The muscles of your pelvis, really, you need to be able to do both. So you need them to be able to be tight to prevent things like incontinence and both fecal incontinence and urinary incontinence, and to support the pelvic organs and help prevent prolapse and reduce symptoms of prolapse. But you also need them to relax completely so that you can empty your bladder completely, you can empty your bowels completely, and you can have intercourse without pain. So pelvic floor physical therapy is really critical to helping regulate both contraction and myofascial release to allow relaxation. Sometimes when women have other conditions, things like prolapse, things like particularly urinary tract infection, where there's inflammation in those areas, those muscles that support the organs, such as the bladder and the vagina and the rectum, can become inflamed and sensitive. And so oftentimes you can have pelvic floor muscle spasms, not because necessarily the infection is spread to those areas, but because of the local inflammation that's going on because of pain and discomfort associated with it. And so pelvic floor physical therapy can just help alleviate some of the tension that's held in those muscles as a result of some of these conditions. Now, is it going to change the bacteria present in the bladder? Probably not. But can it help improve symptoms that are associated with UTI? I think the answer is probably yes. And really, pelvic floor physical therapy has no downsides to it. So there's not really a drawback except sort of the time and energy that it takes to go there. And many women, a few sessions can give them the tools that they need to sort of do those myofascial release techniques and contraction techniques at home. So early prolapse, it can be effective at alleviating symptoms when the prolapse is relatively early. Urinary incontinence, both urge urinary incontinence and stress urinary incontinence with coughing, laughing, and sneezing can be helped with pelvic floor physical therapy. It might not completely alleviate symptoms, but it usually makes them significantly better.
Do you think for some people it might exacerbate symptoms if the area is quite sensitive?
It depends. So if the muscles are really sensitive, it's usually sensitive because they're so tense. So there might be an initial exacerbation before you kind of get the myofascial release, just like with torticollis. I don't know if you've ever had your neck really spasm. Sometimes it can be very, very uncomfortable to do the massage at first to release that muscle and allow it to relax. But then once that initial part is done and you're getting to the point where the muscles relax, it's much more comfortable and you're less likely to have it again in the future.
Okay, that's good to know. We have some other questions about other conditions that might cause symptoms in the same area as UTI that could overlap. The first one is, can uterine fibroids contribute to recurrent or chronic UTI symptoms?
I haven't seen data to specifically say that fibroid, like the presence of fibroids, contributes to the presence of recurrent urinary tract infections. That being said, the size and the location of fibroids is critical for what symptoms that women develop. So fibroids that are on the inside of the uterus, that are near the lining, tend to cause really heavy periods. Fibroids that are more on the outside of the uterus and really large tend to cause bulk symptoms in the abdomen, especially if they're higher on the uterus itself. So depending, and fibroids that are on the back of the uterus near the rectum can cause defecatory function. Fibroids that are in the front of the uterus can cause issues with the bladder because of the proximity of the bladder. So I really think it depends on where the fibroids are, how big they are, as to what symptoms they may cause, because fibroids can be involved in a wide array of symptoms, but it really depends on where they are and what they're doing. Fibroids can create sort of a local inflammatory response too, and neovascularization. So it's not, they definitely can cause urinary symptoms, but they're not, having a small fibroid somewhere in your uterus doesn't necessarily mean that you're going to have recurrent UTIs. I think fibroids really, their predominant symptoms are based on where they're located and how big they are.
What's the treatment for fibroids?
A couple of different treatments. There are medical, and this is not my area of expertise as a urogynecologist, but I'll run you through
Yeah.
what I know. There's medical management of fibroids, both with hormonal medications and things to shrink them down, Lupron and other stuff. So medical management, IUDs can help sometimes with fibroid symptoms, particularly if they're heavy bleeding symptoms. And then ultimately, surgical management of fibroids is really focused on myomectomy, which is like removal of fibroids. And then while leaving the uterus in place, or even hysterectomy, where the uterus is removed with the fibroids either taken out as part of the procedure or left in situ and the whole uterus is removed intact. But that's sort of the overview. Happy to get a fibroid expert
Yeah, I
involved
mean,
if
we
you
should
want one.
interview one at
Yeah.
some point. Yeah, that would be
Yeah.
helpful.
I'm
Um,
like, they're probably up on the more current management. So
yeah, I think the referred symptoms that you were talking about, or symptoms appearing in different places in the pelvis, is a really important topic in our community because people often have overlapping conditions, and we get questions around whether a UTI can cause certain symptoms, and one of those is just urethral pain. Many people with chronic UTI report that one of their only symptoms is often that, and then they wonder if something else might be causing that symptom rather than the UTI itself.
I don't know that we really know. So there used to be a lot of talk about ureaplasma in the urethra, and that if women had urethral pain, you should be testing for ureaplasma. I think that literature has kind of borne out that ureaplasma is actually probably present in many women that
Yeah.
don't have symptoms too, and that testing routinely for ureaplasma or treating for ureaplasma doesn't necessarily make sense.
Yeah.
So if I have women that have had a history of ureaplasma in the past, it's associated directly with their urethral symptoms, and they want to be and treatment made it go away before,
Right.
I will test and treat, or just treat, to be honest, because patients are the best. What worked for patients in the past is my best predictor of what's going to work for them now. So for instance, if someone comes in, they say they had ureaplasma 10 years ago, it was treated with a short course of antibiotics and all their symptoms went away. They got a new partner and all of a sudden it's back again, exactly the same. I tend to treat people based on what makes the most sense for them. Again, this is what's guidelines based versus what's best for patients communication. And I think you just have to really directly communicate with your patients about what makes sense for them versus what's guidelines or evidence based, because I don't think those two are always one and the same, especially in these very, very nuanced areas. In terms of generalized urethral pain, if it precedes a UTI and it goes away with antibiotics, I think it's reasonable to just think of it as part of the UTI continuum. For women with persistent urethral pain, despite treatment with the antibiotics and despite resolution of other urinary tract symptoms, there are even injections that can be performed in the urethra. Again, this is way off of sort of guidelines-based practice, but we definitely do it as part of our practice sometimes for women that, need this kind of treatment. It can be numbing medications or even Botox to kind of relax urethral spasms. There's a growing body of literature on the urethra. Chad Vizina, University of Wisconsin, is starting to do some work into urethra mobility and how urethral mobility may alter or predispose to urinary tract infections based on like the urethra is supposed to help move things out, not allow things to ascend. So I think we really have a lot to learn in the space of the urethra, of how it's sensitized, what kind of things are best to use to treat it. But certainly at this point in time in my clinical practice, I tend to favor things that have worked for patients historically, or discuss sort of non-evidence-based guidelines as might seem appropriate. So, and
I
then
think it's,
topical things too.
well, that's a question. Some people ask if it's possible there's an embedded infection only in the urethra, and if therefore a more topical treatment might be
It might
beneficial.
be, yeah. I mean, it might be. And then I was thinking topical more on the lidocaine side, but that isn't really treating the
No.
underlying condition, right?
Yeah.
That's just make it feel better. I don't know of any topical treatments that have really been done on the urethra itself. I think we really need more research to
Yeah.
understand that, but it's not implausible that that could be going on. I think we just don't actually know.
Okay. Some people also ask why a UTI can cause vulval pain or pain around the rectum.
UTIs can cause pain just because the bladder, the nerves that are in the bladder are shared with the rectum. So we know this from a variety of studies and a variety of treatment modalities that we use for this. And this is why constipation cause urinary tract symptoms and feelings of incomplete bladder emptying. So these two are basically on the same neuronal circuit in some ways. And this is kind of borne out by what we use to treat. So there's something called sacral neuromodulation that we use for overactive bladder treatment, but it also treats fecal incontinence, right? So how could stimulating the exact same nerve do both of those things? It's because these nerve roots and these nerve connections are shared between those two target organs. And so that's the thing that makes it really tricky in terms of pelvic discomfort and pelvic pain, is which organ is the culprit can be very difficult, because you can have something going on in one organ and it's cross-talking with another organ, either via nerve signals or via direct proximity and inflammation.
We did get a question specifically about that. Why would a bowel movement relieve symptoms of a UTI? But I think you just explained it.
Because they're just kind of sharing the same wiring, right? So if you, I'm trying to think of like a good analogy for this, but if you have a lot of things on the same circuit, you turn the light switch on and off, like, right, maybe the two lights go on and off together rather than, you know.
Yeah, that makes a lot of sense from experiences we hear where a UTI will also cause a bowel movement, or the constant need to make a bowel movement. It's all just haywire, it feels like, for some people.
Yeah, and we, again, like use the same, we exploit this clinically and can use the same clinical technique to treat both overactive bladder and fecal incontinence, which is sort of an overactive rectum on some spectrum, right?
Yeah.
And so we can pacemake by stimulating exactly the same nerves.
It's for that reason, do you think a TENS machine might help with UTI symptoms for some people?
It's tricky. So we definitely use a therapy called PTNS, which is like a percutaneous tibial nerve stimulation therapy in the ankle. And that's been well documented in large clinical trials for treatment for overactive bladder or urinary incontinence spectrum health. Now, there's less data on TENS units, but it's a similar type of idea, right? That you're stimulating the tibial nerve, but instead of putting a needle directly in it, you're using a transcutaneous stimulation. So there's less data specifically on that therapy versus the needle therapy, but the same idea of treatment and the same nerve that's being stimulated. So, and we know it works with lower urinary tract symptoms. We also know that OAB, overactive bladder / urge urinary incontinence, is associated with urinary microbiome and probably falls on the spectrum of bladder health. So it's not unbelievable that TENS units treatment might help with urinary tract infection symptoms. We haven't actually done it in a large clinical trial. So this is kind of, you know, a transitive property thing, right? So if it works for overactive bladder and urge urinary incontinence, and that's PTNS, which TENS is kind of like PTNS, but not exactly like PTNS. And if we know that that condition is also associated with urinary microbes, could we then try applying that to other conditions? And the answer is probably, but we haven't done it in a large scale. Is a TENS unit going to hurt you? No, I don't think I don't think it's going to cause any harm. And I just can't promise. We don't have the data to support that it'll make urinary tract symptoms better, but there's definitely, it's not super far-fetched either and very low risk.
Yeah, it would be interesting to see some research in that space.
Yeah.
And we've got a question about what vulvar vestibulitis is and what causes it.
My friend Maria Uloco is probably the best person to answer some of this stuff. She specializes particularly in vestibulodynia and vulvodynia. And there are a lot of theories out there, and I'll try to do at least a little bit of justice to some of her work, but please consider interviewing her for a lot of details on this topic. There are a couple of different theories. Some of them are sort of hyperactive nerves, like an increased nerve density in these areas causing pain. And the other theory is more on hormonally mediated vestibulo and vulvodynia, so that there's hormone deprivation, and that's what causes these symptoms to occur. And she's absolutely the world's expert in all of this and has a lot of data supporting, you know, which things might be contributing. There's some data on birth control pills and what influences they might have on this condition. But suffice to say that some of the treatment options that are available are hormonal supplementation to those areas to try to treat pain. And then also topical applications of things like numbing medications to help treat pain as well. And then even removal of the vaginal vestibule in cases of severe pain that's untreated. But I would highly recommend discussing with her all of the details of etiologies and treatment options for vestibular
Yeah,
and
it sounds great.
vulvodynia.
It's an area of interest for our community too, and we would like to do some research in it ourselves. So definitely ask for the
Well,
contact
because I think
information.
there's a huge overlap clinically,
Hmm.
right? And it's very confusing to separate
Yeah.
out urinary tract symptoms from vestibular symptoms because
Hmm.
they're all in very similar regions.
Exactly.
Clinically, we tend to use Q-tip testing,
Hmm.
which is just using a soft, albeit, anything in that area when you have a severe condition is
Yep.
not comfortable, but a soft Q-tip to kind of gently probe areas of the vestibule and decide whether or not the pain is derivative from the vestibule
Hmm.
versus derivative from other sources. So a physical exam by someone that's well trained in these things can be critical
Hmm.
at kind of better ascertaining and pinpointing the etiology of symptoms. Again, pelvic floor muscles too. You can assess pelvic floor muscle tenderness on exam versus
Hmm.
vestibular tenderness versus things that are going on more in the bladder, all by palpation in a very detailed exam. So please be patient with your providers. This is an exam that usually takes time and is
Yeah.
sometimes awkward and uncomfortable. We're not here to torture you. We're here to really try to suss out exactly what's causing pain so that we can provide the best options that we possibly can to make things better.
Yeah. So another question about a different condition was, what is a bladder fistula?
Oh, bladder fistula. So usually we think of fistulas. So fistula by definition is an abnormal connection between
Hmm.
two structures. So fistulas can occur between lots of different organs. The most common bladder fistula, or what we would call a vesicofistula, which is like a fancy word for bladder in medical speak, is a vesicovaginal fistula,
Hmm.
which is a connection, an abnormal connection between the bladder and the vagina. So they usually don't happen spontaneously. They usually
Okay.
happen after some sort of insult, either
Mm.
childbirth or surgery. Iatrogenic causes secondary to surgery is the most common thing, at least in the United States populations, is like an unrecognized bladder injury that then fistulates with the vagina. And usually symptoms of a vesicovaginal fistula is kind of constant urinary leakage rather
Okay.
than urinary leakage that occurs with certain movements or with certain, feelings like having like a full bladder. It's just
Hmm.
happening all the time at low levels. And it's not necessarily always associated with recurrent UTI, and in fact, kind of rarely is. And the reason for that is the bladder is just emptying all the time. So
Right.
there's not really urine that's sitting around there. And the flow is usually from the bladder into the vagina, not the other
Okay.
direction. So fistulas definitely can happen. And
Okay.
the way that we usually assess for this in clinic, if we're suspicious that the fistula is going on, is we can do a simple test where we backfill the bladder with a colored solution, usually with like a little methylene blue or
Hmm.
cyan green, and then do a pelvic exam in the vagina, looking with the speculum to see if there's any green or blue coming out from different regions of the vagina.
Right. That makes sense. Seems like a simple
So
test. What are the
yeah.
treatment options if it is diagnosed?
we we fix it. We do
Hmm.
fistula repair as part of pelvic reconstructive surgery. So
Okay.
usually, depending upon where the fistula is located, it can either be approached vaginally or abdominally, and surgery is the primary treatment. If it's
Okay.
small and it happened recently, sometimes you can continuously drain the bladder, i.e. have a Foley catheter in for a couple of months and see if the fistula will heal on its
Hmm.
own. The thing that keeps fistulas open is urine continually passing through them
Yeah.
because it irritates that skin. And so if you can successfully divert the urine a different way, like through the Foley
Hmm.
catheter, sometimes small fistulas can heal on their own. But if they
Okay.
don't heal on their own with conservative therapy for, 3-ish months, then, or if they're larger, really the treatment is surgical.
Okay. And still on the bladder, we often hear from people who have had cystitis cystica identified in a cystoscopy. Can you explain what that is and whether it's something that needs to be treated?
So Indira Mysurikar is absolutely the expert for
Mhm.
cystitis cystica. I think, so clinically, this is a finding that we see a lot that we
Mhm.
don't totally know what it means. So Indira's got some data suggesting that this is probably some sort of immune response that's going on, and that these are germinal centers underlying the urotheliums. This is some indication that there's an immune response.
Mhm.
I don't think we have any data showing, that, and I'd have to go look and review and see if there's anything that's newer out, that long-term antibiotics or any sort of specific therapy eliminates cystitis cystica.
Okay.
We see cystitis cystica more commonly in women that get a cystoscopy and have a UTI at the same time as their cystoscopy, or have had a recent UTI and are recovering. So it seems very plausible, and Indira's work supports that it's an immune-based response. But whether or not, and and I don't know that we've surveyed people frequently enough with cystoscopy, like before, during, and after UTI to see what the normal course of resolution is, right?
Yeah.
But in theory, if it's an immune response, the immune response resolves, you would expect it to resolve, and if it's persistent, it might still continue to be there.
Okay.
But clinically, we don't know what to do about it, and there's not like specific treatment that's recommended based on the presence or absence of cystitis cystica.
Okay. In your own practice, when people show up with UTI symptoms, what's the most common condition that causes those symptoms that is not UTI?
It kind of depends on what the symptoms are. So urinary urgency and frequency without sort of any evidence of infection, the most common condition would be something like overactive bladder.
So I want to talk a little bit about testing. What UTI testing methods do you utilize in your own practice?
I mean, I'm embarrassed to say it, but we still use the standard urine culture quite a bit, even though we know it's an awful test. And the reason for that is that we don't really have awesome other options. In my practice, we also do what's called expanded quantitative urine culture, which I know you guys have done some videos and things on before, but in brief is just urine that's cultured under different conditions and with a colony threshold count that's a little bit lower to help detect more uropathogens that are detected by a standard urine culture. In my clinical practice, I only do this on catheterized urine samples, and the reason for that is that the microbes in the vagina are in such high concentrations compared to the microbes in the bladder that it kind of washes out the results of the test to do it on voided urine versus catheterized urine. So that is a limitation of the test clinically, is that really we need to do it, and we know we need to do it probably on catheterized urine to have a really good idea of what's going on.
Is the expanded culture something other clinicians can offer just in your lab?
I don't know. It kind of depends on their microbiology laboratory. So the conditions are published, and so there's a growing number of labs that are offering this, or if you call and you specifically ask for them to do it, are able to do it.
Okay. Do you think
or offer variants on it?
Okay,
So
sure. Do you think taking antibiotics increases the likelihood of a negative UTI test?
yes, absolutely. Especially by standard urine culture tests. So if you're on antibiotics and the antibiotics are present during the culture, the antibiotics can inhibit microbial growth, even if it wasn't necessarily doing a great job in your body, if that makes sense. So having antibiotics present, and the bacteria might be there, but they might be dead and they might not be growing the same way. So usually if you're trying to look for what microbe is there, being off antibiotics is the optimal way to know what's going on in terms of what's alive and growing. At the same time, sometimes I will do cultures while women are on antibiotics to see if there are organisms that are growing despite antibiotic treatment.
Makes sense.
So it's my clue that the antibiotic is not doing what I think it's doing. So these culture and sensitivity results are, I don't know, they're great, but they have limitations, right? It's very useful to have some clinical guidance as to what antibiotic to use, but those antibiotic sensitivities are tested in a laboratory. It is different than what's going on in your body.
Yeah.
And so despite having culture results that say this antibiotic should work, they don't always work. And so if I have a patient where I've treated with antibiotics based on the culture results saying this one should work, and she's telling me my symptoms are getting worse despite all of this, those are the times where sometimes getting a culture in the middle can tell me what's either continuing to grow or thinking about switching antibiotics, because for whatever reason, even though in the lab it seemed to work, in real life it's a different story.
In addition to like urine culture or other UTI testing, is there testing you do around that to try to help build a bigger picture of what's going on with the patient?
Yeah, so we do, I think the biggest portion is really a detailed physical exam and checking for bladder emptying. And then check it, because you need to check the overall tissue health in the vagina, look for vaginal atrophy, look for other things you can do, check for vestibulodynia, check for bladder emptying, check for prolapse. So I think the most important components, in addition to the urine culture, is really a physical exam. You can look at pelvic floor muscle sensitivity, figure out what other things actually need to be addressed.
Is there any test that can identify the presence of an embedded infection?
Not that I'm aware of. So if you know of one, let me know. I would love to know. I know there are some studies that have taken bladder biopsies, but a bladder biopsy is a pretty invasive procedure.
Yeah.
And just because there is an embedded infection, we don't always know what we would do differently or what the antibiotic regimen might be in terms of long-term antibiotic use. There are definitely people that are treated with antibiotics for prolonged periods of time and even prophylactic antibiotics, but it's not, there's an established modality. Sometimes in our clinic, we also treat with antibiotics just in the bladder alone, via catheterization. So what's called intravesical therapy, particularly when there's multi-drug resistant bacteria, or we're trying to target the bladder specifically and spare things like the kidneys and other stuff from antibiotic exposure. Now, I think there's a little bit more to be done as to whether or not this is a better or worse method than oral antibiotics. It has its own problems, right? Because it requires transurethral catheterization.
Yeah.
And it only treats the bladder, which there's some data to suggest gut microbes might play a role in this, and that if you're only treating the bladder, maybe you're leaving out gut microbe treatment.
Yeah.
So I think it's a little bit complicated and complex, but it's at least another option that's not systemic antibiotic administration.
Okay, and you mentioned earlier in the interview about ureaplasma. We often get emails about that organism. Is it possible to identify that with a culture?
With a urine culture? Not on a standard urine culture. I believe for us, we have just a swab that we do. So I think it's a PCR test, if I remember correctly. I'd have to double check.
That's what I assumed as well. And someone asked if H. pylori is something that should be tested for people with ongoing UTI symptoms and if it could be connected in any way.
I don't know of any data connecting it, but that doesn't mean that there isn't. H. pylori is really associated with ulcers, gastric ulcer disease, and so thought to be the major causative organism of gastric ulcers, and the treatment of H. pylori seems to relieve this. Now, the interplay between that and gut microbiome and UTI, I'd have to go do a little bit of research on.
Yeah.
It's not so far-fetched that there could be one, but I don't honestly know the literature well enough to say conclusively that there's a relationship or that you should go get tested for H. pylori if you have recurrent UTI. I would get tested for H. pylori if you have symptoms of gastric ulcers.
When someone does come to your clinic, has classic symptoms of a UTI and tests negative for UTI, what do you do then?
That's a very good question. It's a little bit tricky. So when people test negative on standard urine culture and they have UTI symptoms, I usually talk to them about a couple of different options. I talk to everybody about conservative management of UTI anyway, and I usually do conservative management of UTI while awaiting culture results in the first place. There are data out there to suggest that about 25% of women, even with bacteriuria, so they're positive on a standard urine culture, they have severe symptoms, 25% of women will clear it on their own with ibuprofen, Tylenol, and increased fluid intake. So I always offer conservative management of UTI in lieu of antibiotics to patients if they want it. Now, that is not for everyone, it's quite a commitment. But there are patients that would like to try that or like to try clearance through that mechanism for at least, a period of time before proceeding with antibiotic therapy. And usually I recommend that while awaiting antibiotic therapy or decisions about antibiotic therapy in recurrent UTI patients, just because I'm waiting for an idea of which antibiotic I should prescribe. So that's always an option. The second option is empiric antibiotic treatment. So that's best guess as to what antibiotics might work. Sometimes I can base that off of previous cultures. Sometimes I'm guessing more based on what their allergies are and other things to select an antibiotic that's least likely to cause them other sorts of problems since we're doing it empirically. The other option that sometimes comes up too is that women with recurrent UTI tend to be very, very sensitive to UTI symptoms. So even though the first culture isn't positive, sometimes a second culture can be positive. So sometimes I'll even offer a second culture, either voided or catheterized or potentially equuck, right? So some other culture modality to kind of get a sense of what organism is there. But these all have, this is a very personal discussion with a given patient, right? So there are patients that are like, look, I don't want to have antibiotics until I know what this is and I know what the bugs are, in which case I'm like, let's come back, let's do another culture. If you can stand a catheterization, a catheter based culture is probably going to give me a better idea of what's going on. And we could even do expanded quantitative urine culture in that case, but that's a commitment in coming back into clinic.
Mm-hmm.
There are other women that are like, look, I don't care what it is. I just want it gone. Let's just try an antibiotic, in which case we do sort of a low risk empiric antibiotic because I don't want to jeopardize health or well-being of other organs, right? And then for women that are like, look, I just kind of want to wait it out and see how things go. Maybe it's getting a little bit better and I think I could stick it out. Then we can proceed with expectant management and sort of conservative interventions for UTI and sort of reassess how things are going. And I think either of those are reasonable. In women that are high risk of having things like pylo, older populations, that kind of thing, sometimes things change, but these, these are general offerings, and then you tailor it to the things that make the most sense for a given particular patient.
Given the limitations in clinical practice, do you find that patients are able to break the cycle and stop experiencing all the recurrences of UTI?
Yeah, and we do. It's just that I think the people that don't respond to sort of our conventional or more traditional therapies, then it becomes a lot more challenging, right? So we know that vaginal estrogen cream, which is our most common intervention for recurrent UTI, works really well, right? So it reduces urinary tract infections. I'd have to double check the data, but it's about threefold, right? So it does work, but for women that it doesn't work for, then it becomes a little bit more tricky. We also know HIPREX reduces risk of recurrent UTIs. The D-Manos data, at least from the most recent JAMA publication, is not pretty impressive, but for some women, D-Manos works really well. And I think one thing I want to highlight from that is that even though that clinical study didn't show that D-Manos was effective for that population, there's no substitute for what works for you, right? So if I have patients coming into me saying that D-Manos made things a lot better or wanting to try it and having reduction in symptoms, that's better than a clinical trial saying it doesn't work, right? So if there's a low risk preventative that works for you, that's better than large data of any type, right? So I think the trick is just figuring out, how to tailor UTI preventives and how to tailor UTI treatments, because not all women that experience recurrent UTI are the same, right? And so I think right now we have a one size fits most sort of guidelines, and it helps tremendously for people that have tried nothing before. But for the women that have tried lots of things, it becomes far more nuanced, far more tricky, and a little bit more complicated. And so those are the women that are going to have a lower likelihood of having the cycle broken because they've already not responded to our usual armamentarium, if that makes sense.
Yeah, we definitely see that in our community, and that's definitely who we provide content for. So it's good to talk about that.
So I guess, I don't know, our guidelines-based treatments do work, but they work for a certain segment of the population. But once you kind of break out of the easy to solve problems and you get into the more difficult to solve problems, then it becomes a lot more complicated. And those women are the women that it's harder to break the cycle. You really need a provider that can talk to you, spend time with you, figuring out what's going on and what's unique to you, and can really offer you options of care that are beyond the scope of guidelines-based practice and interact with you in a meaningful way. So if you're just someone who's never tried anything and you need some vaginal estrogen, that's easy. Most providers can provide that really readily. I think it's the people that have failed. I don't want to say failed. Those treatments have failed you, right?
Exactly.
Like those treatments have failed you. You have not failed. We have just failed to understand why you have recurrent UTIs. Those patients are the ones that really need specialized, dedicated care and really interact with providers that are a little bit more familiar with things beyond the normal standard management.
Yeah, couldn't agree more.
So.
Well, this has been very insightful. I wanted to thank you again for answering all our questions, and I really look forward to the follow-up where we talk more about the science.
Awesome. Sounds great. Thank you so much, Melissa.